Thank you for listening to this brief education on nurse-led sitter guidelines that's coming in 2025 or January, February of 2026 to your unit. What are the nurse-led sitter guidelines? So this is really a chance for nurses to decide whether most patients are going to need a sitter. Using an algorithm, you'll decide whether they need a in-person or a virtual sitter. There are a few exclusions, and providers will order a sitter for these patients. So suicide precautions or ideation, high-risk ASQ screen, an eating disorder diagnosis, or concern for factitious disorder or factitious disorder by proxy, formerly known as Munchausen. Why are we making this change? So in most cases, determining if a patient needs a sitter is within the nursing scope of practice. We also know that nurses are usually the ones requesting that a patient get a sitter. They're the ones who recognize that it's needed or not needed. So this change eliminates the middleman and increases nurse decision-making and autonomy. There isn't a solid process for reevaluating if a sitter is needed current state, so this also allows for reevaluation and removing sitters when they're no longer medically needed, increasing the number of support staff on the floor. This is also evidence-based. Recent literature shows increased nursing satisfaction, decreased use of sitters when there's no medical need, and there's no decrease in patient safety metrics when virtual sitters are combined with a nurse-led sitter program. So what do you need to do? You're going to decide if the patient needs a sitter, and if they do, you're going to use the sitter initiation algorithm to determine if the patient should have a virtual or in-person sitter. And then you're going to reevaluate at least daily, but more often if needed. And using the sitter escalation and de-escalation algorithm, you'll determine if the sitter should remain the same, be changed to a different type of sitter, or be discontinued. So there's two algorithms that will be available in the policies and in the JITs. So the first is the sitter initiation algorithm, is the initial assessment. So you're going to determine that your patient needs a sitter and then use this to determine what type of sitter is needed. So up at the very top those are the populations that the provider will order a sitter for, and after that you'll look at the reason that your patient needs a sitter and follow the algorithm down to determine what type of sitter they need. Some key things to know: if your patient qualifies for an in-person sitter during the day but they sleep well overnight, consider an in-person sitter during the day and a virtual sitter overnight. If your patient has a sitter due to behavioral outbursts, start with an in-person sitter and talk to the behavioral assessment team. Together, you'll decide if the patient qualifies for a virtual sitter. If your patient has a history of complex medical needs and has had a sitter every time they've come in, you can use your discretion to decide if they still need a sitter. It's okay to order an in-person sitter if needed, even if the patient doesn't qualify for one per the algorithm. The next algorithm is the sitter escalation de-escalation algorithm. And once again, the populations that the providers order sitters for is at the top. You will not change any orders related to these populations. Other than that, even if the provider orders a sitter for a different reason, you can decide if you're going to continue with an in-person or virtual sitter or discontinue the sitter. And so once again, you'll find whether you have an in-person or virtual sitter and follow that algorithm up and down to determine what kind of sitter you need and whether you can de-escalate or discontinue it. So a few key things to know: if your patient has a sitter, reevaluate need at least daily or more as needed. If there's no change to a sitter need, then no extra documentation is needed. If a sitter change is needed, then you're going to change the order, and you can look at the JIT for instructions for that. Moving from an in-person to a virtual sitter is recommended for most patients because it gives an extra level of support and monitoring in case of concerns. But if your patient no longer needs a sitter, so for example, they came in after an ingestion to get high, they are a little bit confused, but now they're back at baseline, it's okay to discontinue the in-person sitter without moving to a virtual sitter. Here are some resources that are available. The policies are not on Connect soon, but they are going to JCPC and MEC in January, so they should be available by February. In the meantime, they are going to be in a virtual sitter notebook at your B station that should be available as you start education for this. So the policies are the patient sitter PNP, the virtual sitter PNP. There are a couple JITs, the nurse-led sitter guidelines JIT and the virtual sitter for bedside staff JIT. There's also a teaching sheet, the patient sitter. It is currently being translated into Spanish, so if it is not available now, it will be available soon. In the meantime, it is in that virtual sitter notebook. If you have any questions, please reach out to your clinical nurse specialist or your clinical educator. Thank you very much.